Treatment notes. Objective measures of language style point to clinical insights. Part 4. Clinical evaluation directed by language scans and comparison with failed case. In this discussion, we illustrate the nature of the analytic work during the second year, comparing a segment from the beginning of the second year, when MHW is low, October 1972 through March 1973, and the analysis is in danger of following a course similar to that of 50T1, with the following segment, April through September 1973, when MHW returns to a higher level than REF. MHW then remains elevated for 3 years until discussion of termination is begun. At that point, there is another decline in MHW and an increase in REF, leading to the second negative difference score of this treatment, represented as a crossover of the language measures. Here, as following the first such pattern, there is recovery of the treatment, allowing for successful termination. We will focus on the first nodal period with a negative difference score, October 1972 to March 1973, that was then repaired in the subsequent phase. We note that this crossover period occurred at comparable time early in the analysis as the period in case 50T1, spring 1952, where MHW and REF converged and there appeared to be some potential for repair of the treatment. In contrast to patient 50T1, who was aggressively assertive, this patient presented at the beginning of treatment as inhibited and anxious. The analyst noted that because she was frightened to use the couch, she jumped and lay down immediately. She created a ritual way of preparing herself every time to lie down and preparing herself to leave at the end of the session. She often complained of the difficult trip to the analyst's office. A clinical vignette in the beginning of the analysis is an example of the engagement of the therapist as indicated by the vividness of the language. In the analysis, the feeling mounted that I didn't really care about her, especially after times of absence. Finally, she went into a rage and insisted on sitting up for a session in which she told me just how angry she was at me. In this session, she announced that the only way she could be sure that I cared about her is for me to be available at all times when she needed me. She was enraged that she had to ring the bell 5 times before I had answered it, that she had the feeling that you didn't pick me, you're stuck with me from the institute. Again, she had the feeling that she was upset either because it was her fault or my fault or her mother's fault. Next session, she felt embarrassed about her behavior. She could reflect that her anger at the analyst was excessive and she didn't know why, marking the beginning of the analysis of the transference. She went on to describe her chronic fears whenever she was confronted with her children or husband not being immediately available to her. She would often be fearful that something would happen to her children on their way to school or if they were late. When she left to go to an analytic session, leaving her husband and children together in the house, she was concerned that something would happen while she was gone. She felt that her analysis might be bad for them, i.e., take something away from them. Following this initial period of analytic work indicated by high MHW, the MHW declines below the REF. In the segment of October 1972 to March 1973, the patient discussed a variety of traumatic and potentially traumatic events in her life and in her family history, the severe illness of a friend child, and thoughts about close relatives who had suffered traumas. During this time, she wanted to feel closer to the analyst for protection, just as she felt protective of her friend whose child was ill, and became obsessed with images from stories she heard about the traumatic events suffered by her relatives. She reported how frightened she would become and how she would feel guilty for being alive, unlike those children who had died. The analyst reported that over this time, it was very important for the patient to feel that she was doing the analysis herself, and would often feel that the analyst's interpretations were attempts to prove that she couldn't handle herself alone or that the analyst knew more than she did. The patient reacted to separations from the analysis by insisting she did not need to be in analysis anymore. This may be compared to the comment by patient 50T1 that he should not come for the last few weeks before the analyst's vacation. Toward the end of this period, the patient, reporting a dream of a dilapidated house where everything was falling apart, defiantly asked the analyst what it meant. When the analyst suggested she talk about whatever idea she had about it, she refused to do so, saying that dreams didn't mean anything. During this segment, in the face of disturbing associations from her current life and memories about her family, it seemed as if the analyst could say nothing helpful. Over this time, the analyst wrote, it was very important for Mrs. X to have the feeling that she was doing the analysis herself. She would often feel the analyst's interpretations as an attempt to prove that she couldn't handle herself alone or that the analyst knew more than she did. Both from a clinical reading of the analyst summary and looking at the language style, it seemed as if the connection to the analyst and the analysis was in danger, with many unexamined negative feeling states toward the analyst. The analyst did not report any associations that she herself might have had about the dream of the dilapidated house. With all the negativism present during this time, we might speculate that the dream image may in part represent the danger of the analysis falling apart, as the patient threatened to interrupt the analysis. She really didn't need to be in analysis. She could do it herself. During the next 6 months, April through September 1973, negative feeling states continued to pervade the notes. The major themes included the patient's envy of other women, envy of the analyst, and competitive feelings in her professional life, together with the conviction that professional criticisms were personal attacks. At the same time, she castigated herself for her envy and depression and felt that the critiques of her work were warranted because she lacked sufficient credentials. At one point, the theme shifted to children, and she talked about her friends having babies. She was concerned that her husband would lose sexual interest in her if she did not have a third child. The analyst wrote the following. Typical of her defensive character style was that in response to this, she again became extremely angry and stated that women just have third children to get away from themselves. When the analyst pointed out that if she were so angry, she must be upset about something, it increased her anger and defensiveness. What finally emerged was that she, indeed, did have wishes to have another child and was fearful that if she allowed herself to be aware of those wishes that she would have to do it. This was the beginning of her understanding that she could have mixed feelings about things and still make a choice, that she didn't have to bury one of the feelings under the anger and defiance. This conceptualization and interpretation by the analyst may be calm, paired to the conceptualizations and communications by the analyst in 50T1 at a similar phase in the treatment. In contrast to that case, here the analyst directly addresses the defensive nature of the patient's anger. If you are so angry, you must be upset about something. This line of intervention let the patient understand that one can have mixed feelings. At a point before the summer vacation, patient 50T1 discussed his upset feelings about being abandoned and his wish to retaliate against the analyst. In contrast to the analyst in case 70T3, who focused on mixed feelings and the defensive use of anger, the analyst in case 50T1 focused solely on the patient's provocation, intended to get an angry response from him, and avoided communicating the defensive nature of the anger, even after the summer break. As the summer break of 1973 approached, patient 70T3 continued to discuss her fear of having good things for herself, or even to wish for positive things, like having a baby, because of her fear that they would be taken away. Point 5, her concern about missing the analyst was masked by anxiety around the possibility of her own pregnancy, which did not occur. The analyst noted that upon her return in the fall, she spent a good deal of time longing for the freedom of the summer and stated that she was sad because she was back in the city. She talked about how she might want to move and how she certainly was not going to allow the analysis to make her stay. The analyst reminded her that this was similar to her response last summer when she had come back after a summer in which she clearly missed the analyst, saying that she was thinking that perhaps now she should leave treatment. Again, she was reminded of her difficulty in experiencing her warmer feelings about the analyst. She laughed and the feeling subsided. We may interpret that the analyst here is in effect asking her to stay. This can be contrasted with the shift that occurred in the process for patient 50T1. As with that process, the major focus in September 1973 continued to be on the patient's denial of needing the analyst over the summer. However, the analyst in case 70T3 was able to communicate an understanding of the patient's need for closeness, in contrast to the analyst in case 50T1, who focused primarily on the patient's fear of submitting and on his defensive aggression. Throughout the analysis, particularly during the nodal points, the analyst in case 70T3 continued to interpret the patient's mixed emotions. Later on, toward termination, during the second nodal period, for example, the patient had a dream in which she was leaving for college and her mother asked her to take a later train. It was interpreted to her that she had mixed feelings about both her mother and the analyst asking her to stay. She wanted them to ask her to stay, but protected herself against hurt feelings by insisting she wanted to leave. The patient responded that she was not aware of a wish on her part for the analyst to ask her to stay, and then went on to describe how she felt that there was no reason for the analyst to care whether she was leaving or staying. She said that she understood that she was in treatment center analysis and that the analyst was getting an education out of her analysis. Again, it was interpreted how much she had to ward off her own feelings of wishing that the analyst care about her, as she had the concern that her mother didn't love her. 5. The segmentation of this long treatment, given by the 6-month summaries, left the periods before and after summer vacations within the 6-month periods, so that the dynamics surrounding those phases are not reflected in the figures. A different segmentation structure would allow such an examination. Clinical conclusion. The differences between the two analyses are quite dramatic, as indicated by the outcome measures and language style analysis presented in the figures and discussed in the text. At similar points of threatened rupture in the treatment, the analyst in case 50T1 does not seem to appreciate the patient's connection to him, does not address conflict or ambivalence, wish to leave/wish to stay, aggression/love, and does not directly address defenses against wishes for closeness in the transference. After a brief period of emotional connection with the patient, the analyst could not continue the connection. By contrast, the analyst in case 70T3 understands and interprets that the patient wants to be asked to stay, but protects herself from hurt by threatening to leave. In sum, it seems the analyst in case 50T1 did not like, or was afraid of, the patient's connection to him, perhaps particularly the homosexual transference, whereas the analyst in case 70T3 appears to have appreciated the patient's connection to her. Analyst 50T1 would not or could not understand this central dynamic and communicate it to the patient, whereas Analyst 70T3 was able both to understand the patient's central dynamic and to talk to her about it. Finally, Analyst 50T1 focused on content interpretations, whereas Analyst 70T3 focused on the process, particularly the transference relationship. The analysis of patient 50T1 was interrupted by the analyst shortly after a year and a half of work. The analysis of patient 70T3 continued for 6 years. Discussion. It is striking that the computerized language measures, based on two interacting variables, have pointed to corresponding moments in two contrasting treatments with starkly different outcomes. Clinical examination of these phases has suggested how the analyst's activity may have affected the course of the analysis. The linguistic analysis allows for a microanalysis of clinical material highlighting points that might be missed in the customary clinical review. Use of such a method might have helped in the supervision of case 50T1 and in the conduct of this treatment of a patient who was initially seen as having an excellent prognosis but then deteriorated. The utility of this method, of course, needs to be verified by further studies. If computerized linguistic analysis of process notes is done prospectively, this technique has the potential to provide analysts and therapists and their supervisors opportunities to refine interventions with patients. For example, had linguistic scans been available in the case of 50T1, the analyst and supervisor could have seen that something was going wrong in the sessions before the first summer break, something not clinically discerned. Analyst and supervisor may then have become more aware that the response of the patient to the separation was not being dealt with effectively. Limitations and future directions. An important question that needs to be addressed is whether the finding in this exploratory study of two sample cases, a male analyst treating a male patient and a female analyst treating a female patient, can be replicated with other cases and other gender configurations. Can differences in the linguistic pattern of case write-ups reliably differentiate successful and unsuccessful analytic work and successful and less successful interventions? Our clinical analysis of the therapeutic work during nodal periods indicated that more effective clinical work occurred concurrently with shifts in the language curve. A more fine-grained analysis of the linguistic measures, e.g., a time series analysis, would be required to determine whether the clinical effectiveness followed was concurrent with or preceded those shifts. Can our language measures provide a way to study the construct of analyzability and its problematic predictive capacity? Backrack 1983. Help us address the problem of patient dropouts, Hamilton, Winninger, and Roos 2009, and help us understand the effectiveness of the supervisor, analyst-patient triad, Kantrowitz 2002. Two cases that were dramatically different from each other. In terms of their language scans, their initial GAFs, but not their initial AVER, age PFS, and their clinical outcomes, were chosen for illustrative purposes. This choice of two cases, very different from one another and treated during different psychoanalytic eras, may confound the conclusion that the language measures can reliably differentiate success from failure. In future work, the method would need to be tested on a large sample of different types of treatment. The clinical notes made available to us from the archives of the treatment center varied in both length and level of detail. Preliminary within-case comparisons did not show differences in the language measures among different kinds of notes, daily notes, weekly notes, 6-month summaries. However, none of them Real was in the form of process notes and did not include extensive descriptions of he said, I said, back and forth. It would be instructive to examine whether linguistic analysis of detailed process material yields results similar to or different from those drawn from more general case descriptions. Conclusions and clinical and professional implications. The clinical evaluations of the treatments used in this study, provisional as they are, point strongly to the need for a monitoring of treatment effects beyond the usual supervisory practices. The 14 treatments included in this study were carried out by candidates in a highly selective psychoanalytic training institute and were supervised by senior analysts. Yet 7 of these patients showed essentially no improvement based on the composite clinical evaluation, with a CCE of 0 or 1, Table 1, as reported in our initial study, and 4 in fact became worse. While it is possible that other clinical ratings might have provided a different picture, the proportion of success and failure is not so different from that reported in other studies of comparable treatments. As reported by Bucci, Maskit, and Hoffman, 2012, 6 of the 17 cases included in an archival study by Lubersky et al., 2001, showed little or no improvement. Of the 22 psychoanalytic cases studied in the Menninger found, Detaillon Psychotherapy Research Project, 9 were considered equivocal or failed, Wallerstein 1986, page 74. Major clinical difficulties include problems in assessment and in predictions of analyzability, Backrack 1983, problems with patient dropouts, Hamilton, Winninger, and Roos 2009, and the long-standing problem of therapeutic failure, Obendorf 1948, Gold and Stricker 2011. Clinical evaluations often are difficult and are often wrong in their prognosis, as seen in the cases reported here. One was considered an eminently analyzable patient, with many laudatory comments by evaluators, yet had a failed analysis within 2 years. In contrast, the evaluators of the other patient had mixed feelings about her capacity to undertake psychoanalysis and come to a satisfactory conclusion, yet she turned out to have a successful analysis. In addition, In training cases, the nature of the supervisory experience, as well as the analyst-patient match, may play an important, yet often unexamined, role in the progress of the treatment, as Kantrowitz, 2002, has pointed out. Obendorf's list of the types of failures with psychoanalysis, 1948, is still relevant to contemporary practice. He identified 4 classes of failures. One group, which he found particularly challenging, comprised cases in which the patient's personality and symptoms seemed to justify the application of classical psychoanalysis, yet the treatment ended with unsatisfactory results. The other classes of failures included cases where mild symptoms masked deeper pathology, where there were difficulties in applying the method, and where external conditions posed difficulties. Similar problems are seen in studies of other forms of psychotherapy. Professional responsibility in the psychodynamic field, as in all treatments, requires that we address the fact that treatment fails many who seek our help. Outcome research is not sufficient to address these problems. Process research is required to address the nuances of the treatment interaction in a timely fashion. Optimally, for research purposes, the computerized analysis of treatment notes that has been illustrated in this paper should be embedded in a study, including external evaluation of treatment effectiveness, ideally through measures administered prospectively, at intervals in the course of treatment, at its conclusion, and at follow-up. In such a wish list study, sessions should be recorded and transcribed, and computerized measures applied to the transcripts. Such a study would enable us to address a range of questions concerning the relative value of language style analysis of notes and of transcript material in predicting outcome. We could also address the relation of notes and transcripts, asking what is covered in one that might be missing in the other. The value of notes is that they are widely available. They're used in many or most supervised treatments and in treatments by practicing therapists and analysts at all levels of seniority. These days, analysts and therapists can record their session notes in a password-protected, HIPAA-compliant manner on a computer, often close to the time of the session itself. By contrast, the transcription of audio tapes generally involves considerable cost and lengthy delays. The real-time digital processing of notes would in principle allow the language style analysis to contribute to the supervision or to guide the practitioner's recognition of a difficulty in the treatment as the situation is evolving rather than long after the fact. The method proposed here has the potential to help analysts understand where an analysis is going or has gone right, and where it is going or has gone wrong. With this understanding, we can modify our analytic technique in an ongoing way to fit a particular patient's needs at a particular time.